All right, well, I'm really happy to be here, and it's thanks for the invitation, and nice to get to interact with all of these wonderful young pediatric oncologists. Ooh, I won't touch that again. Okay, so I just came back from ASCO, and at ASCO they have revised the way in which the presentations are done. And they say it enhances learning. And so I am using that model here. I'm going to tell you all the high points on all the highlights of my talk on the first slide, okay? So I'm going to talk about presentation and epidemiology and the implications for research. And in particular, the key take-home message here is that it's a cancer of young people. And so you need pediatric and medical oncology collaboration in order to make progress in this disease. It's also quite rare. And so national and international collaboration is also essential. I'm going to talk about natural history and lessons learned from our early clinical trials. And here, this is maybe my key take home. The way I interpret that is that development of new metastatic disease is the manifestation of treatment resistance. And the whole field of treatment resistance needs a lot more study in osteosarcoma. Then I'll talk about the last 30 to 40 years, a few of the highlights of clinical trials, and address the question of whether we've made any progress in treatment. I'll speak about mefamutide, ifosfamide, and what we understand about clinical risk factors. I would say the answer to this question is we've learned a lot. I don't know that we've made much progress in treatment. I'll talk about clinical trials of new therapies, and essentially these are performed in the recurrent disease setting. We use a primary endpoint of 4-month event-free in the United States setting. We're able to use that and do single-arm trials and look at a number of different therapies in relatively rapid succession. And the outcome of these clinical trials and new therapies have really identified multiply targeted kinase inhibitors as active therapies in this disease. And then we'll talk about precision oncology for osteosarcoma, and here I hope you'll see that we may succeed by addressing pathways instead of single genes, or at least that's the approach we need to take. And we need to, and I think will, identify biologic subgroups in this disease, similar to sort of what you are experiencing in all your other cancers, where you have sort of high, intermediate, and low-risk groups of patients. I think we will do that in osteosarcoma in the next 10 to 15 years. And then finally, I'll share with you a couple of my tips for patient care. Okay, so I think you all know this already about osteosarcoma, but I like to start here just to make sure we're all on the same page. So in general, the presentation of osteosarcoma is quite clear. It's unusual for us to go to our tumor board and look at imaging and hear the history of a new patient and not know that it's osteosarcoma. So typically, patients present with, I think it's on average, 4 to 6 months of symptoms of pain in a particular location, often accompanied by swelling, although not always. The most common site of disease is around the knee and the distal femur or proximal tibia, but then essentially any bone in the body can be affected. But the next most common is the proximal femur, the pelvis, the proximal humerus, and then the distal tibia. It's a disease of young people, as I said. So let's see, this is the pointer. This is the age distribution using our national registry in the United States. And what you can see is the peak for girls is earlier than the peak for boys. That peak occurs really coincident with the rapid linear growth that adolescents undergo. But it's a disease that goes all the way up into, actually, I'll show you on the next slide, into the 80s with a lower peak. And then if you take an entire population of patients with osteosarcoma, 40% of them will have metastatic disease at some point. About half of those have that metastatic disease at diagnosis, and the other half develop it at recurrence. And lung is by far and away the most common site, but bone is the second most common site after lung. So this is a little bit more of a deeper dive into the epidemiology, and it's along with a recent update. So this is a paper that uses our what we call our SEER database, which is a compilation of a bunch of state registries in the United States. And what you can see that there has been an increase in incidence in the 10 to 24-year-old age range since the early 1980s. I don't think anybody really understands that. Oh, by the way, this is divided into primary osteosarcoma, which is shown over here, and subsequent osteosarcoma. So that would be osteosarcoma as the result of treatment. It seems as though primary and subsequent osteosarcoma are both increased somewhat in the 10 to 24-year-old age range. Don't ask me any questions about that. I have no idea why. There's an increase in incidence in secondary osteosarcoma in patients over age 60. That's what this bar is, and that's probably just survival from other cancers where radiation is used as a treatment, because radiation is definitely part of the etiology of this disease. Another point, there is an incidence of osteosarcoma that goes all the way up into the older age range. However, the height and the width of this second incidence peak is much smaller, and so the total number of patients who are older and have that have osteosarcoma is actually much smaller than our young adult adolescent and young adult patient population. And it's probably got a different biology because it's much more dominated by secondary. And it's also where you start to see osteosarcoma related to Paget's disease, nothing you have to worry about because you won't see it in your kids. The pathology is completely, usually entirely straightforward. So you'll see sort of high-grade malignant cells with producing malignant osteoid. Interestingly, at least I think at my center and I think everywhere, the pathologists are trained to look at the pathology in conjunction with the radiology. So you do our pathologists typically like to see those histologic features in combination with typical radiographic features. There are histologic subtypes in osteosarcoma. The most common is the conventional or osteoblastic osteosarcoma, with other histologic subtypes being much less common. There is actually prognostic significance of the histologic subtypes, which I'll come back to in a minute. We use our own staging system. I'm not sure why we had to make up our own. I mean, I understand why. It has to do with kind of the bone. But almost all patients are 2B, which means that the tumor has extended outside of the bone itself and is high grade. So almost all the patients you see will be 2B. And so in general, when we're talking amongst our colleagues, we really just say, is it localized or metastatic? And really what we mean is it's either stage 2B or stage 3, which means regional or distant metastases. About 5% of patients will have surface osteosarcomas, which are the para-osteal, which is generally a low-grade tumor, and peri-osteal, which is usually an intermediate-grade tumor. Everything that I will talk about is really about the high-grade intramedullary tumors, which are those 2B patients. And then I won't talk much more about it here, but that's my dog, Ruby, and dogs get osteosarcoma. She doesn't have osteosarcoma, but if you hear people talk about osteosarcoma, I'll show actually a slide from a canine trial. So even though I said that the diagnosis is usually straightforward, there are occasionally diagnostic dilemmas. So this is a patient I took care of who enrolled on one of our sequencing studies. He was initially diagnosed with an aneurysmal bone cyst, which is it's a benign type of bone tumor. The treatment for an aneurysmal bone cyst, or ABC, is to do curettage. So this panel A here is his MRI at his initial diagnosis. He had curettage, and then some cement packing, and then he went on his way, because that's what you do for that disease. But a year later, he recurred. So you'll see there's some susceptibility artifact. I'm not a radiologist, but I think that's what that is, where it's very dark because of the packing that he had, and then there are these enhancing regions here and here. So he had a repeat biopsy of that area, and it went sent around to a bunch of different pathologists who thought that some of them thought it was just recurrence of the aneurysmal bone cyst, some of them thought it was low-grade osteosarcoma, and some of whom thought it was high-grade osteosarcoma. So we went ahead and sequenced this tumor, and what we found is a rearrangement of TP53 in intron 1, which is seen in about 50% of osteosarcoma cases. So osteosarcoma almost universally has inactivation of TP53 in the tumor. That can be from mutation. It can be from 2-copy deletion, but about half the time, it's from a rearrangement in TP53 that removes exon 1 from the rest of the gene. And exon 1 is actually not transcribed. It's the transcription start site. So if you remove the transcription start site from the rest of the gene, it's like deleting the gene. You don't produce that TP53 from that allele. So this patient had an intron 1 TP53 rearrangement, and then it was rearranged to USP6, which was inappropriately activated. And interestingly, USP6 is involved in a rearrangement in aneurysmal bone cyst. So we think this was giving him an osteosarcoma tumor that had sort of the histologic appearance of an aneurysmal bone cyst. Osteosarcoma is it's not the only time I've ever seen TP53 intron 1 rearrangements. There's some undifferentiated pleomorphic sarcomas where I've seen it, but it is almost, in this clinical scenario, diagnostic of osteosarcoma. So we called him osteosarcoma and gave him gave him chemotherapy. So there are the occasional diagnostic dilemmas, and I come from a pro-sequencing kind of lens, but I actually think that in this case, if you're able to detect those TP53 rearrangements, it can be quite helpful to sequence to figure those out. Okay, so what did we learn from early clinical trials in osteosarcoma? So this is one of the first clinical trials ever done, and actually, osteosarcoma is pretty unusual. It's one of the only cancers where we did a clinical trial asking whether or not systemic chemotherapy improves outcome. If you think about it, most of those trials were not randomized trials. They were just sort of single-arm trials. Let's give some chemotherapy and see how the tumor responds. In osteosarcoma, there was enough of a debate about whether chemotherapy actually helped or whether there had been some kind of biologic drift or clinical change in the disease, or maybe the surgeons just got better. So we actually did a randomized trial about that. So in this trial, there was primary upfront tumor resection. At that time, because this was done in the late 1970s, early 80s, that was very often amputation. And then patients were randomized to either get chemotherapy or just have the surgery. And you can see that the patients who had surgery have an event-free survival long-term around 20% or less. And 85% of those events are development of pulmonary metastatic disease. The chemotherapy given in this trial included bleomycin, cyclophosphamide, and dexamethasone, which we no longer give. But other than that was essentially the MAP, or high-dose methotrexate, adriamycin, and cisplatin chemotherapy that we use now. So this is essentially a randomized trial of surgery versus surgery plus the chemotherapy that we give standardly in clinical practice, showing an improvement in event-free, and it turns out also overall survival in patients who get chemotherapy. So I'll just mention one other thing that we learned from those early trials, and that's about histologic necrosis. So here we're talking about there was a shift in practice from doing that surgery before the chemotherapy to doing it after 10 weeks of chemotherapy, and then looking at the percent necrosis in the tumor after resection. There's a very standard way in which that's done. The tumor is bivalved, and then there's a grid placed on it, and there's slides taken from every section of the grid. And good necrosis is considered more than 90% of the cells being necrotic. And basically what you see is that if you have good necrosis, you have an improved event-free and overall survival compared to poor necrosis. There's a very important point to make here, though. So if you look at this slide, the middle two lines, the sort of brownish lines, this is good necrosis and this is poor necrosis on one of our clinical trials that essentially gave MAP chemotherapy. And this is sort of what we typically think about, that is if you have good necrosis, your event-free survival is around 80%, and if you have poor necrosis, it's around 50%. But the blue and teal lines are good and poor necrosis from a different clinical trial that gave less chemotherapy, just to make sure that's right, less chemotherapy up front. And then what ends up happening, maybe we gave more actually, I think we gave more chemotherapy up front. What ends up happening is that if you have poor necrosis, at that point, after more chemotherapy, it predicts an even worse outcome, okay? So this points out so necrosis is actually a terrible prognostic factor, okay, for a couple of reasons. Number one, if your surgeon has to do surgery early because they're going on their summer holiday, or they have to do it late, then it's no longer predictive in the way in which it was studied, okay? It means something different. That's one reason. And second reason, you don't have it until after 10 weeks of therapy. And that may be too late to make changes to therapy. Third reason, it doesn't actually tell you, it tells you about the tumor's behavior, but it tells you nothing about the biology. And you actually can't change or iterate on therapy unless you understand the biology that's predicting the poor behavior. This is just an observation of clinical behavior. Okay, so that's necrosis, but we did learn about necrosis. The other thing that we learned, and this is now moving on to a much more contemporary trial, which is Uremos, but it actually reflects on something I said on the prior slide about our initial trial. So in patients with poor histologic response and localized resectable disease, when they looked at, this would end up being something like 500 patients on the Uremos trial. This is what's called a stacked probabilities graph, where it sort of shows you each of the events that those patients had. So you can have new lung mets and death because it's stacked on top of each other. But the most important thing I want to point out here is that the vast majority of events, just like that initial trial of chemotherapy, the vast majority of events for patients with localized disease, with poor necrosis, that happen is they develop new lung metastases. Okay, so to me, what this means is that new lung metastasis is a manifestation of chemotherapy resistance. Why is that important? Why do I emphasize that point? There has been very little work done in osteosarcoma to study chemotherapy resistance. What is it about those cells that makes them chemotherapy resistant? That's compared to many other diseases in medical oncology where, in particular, cisplatin resistance is a biologically well understood phenomenon. And so this is an area where I think we need to do a little bit more work in this disease. Oops. Okay. All right, next topic, 40-year progress in treatment, question mark. So we've been doing clinical trials of changing treatment, changing chemotherapy or adding new things or administering it in different ways over the last 30 to 40 years, ever since we found that giving chemotherapy was helpful. And the question is, have we made any progress? Have we learned anything? I'll tell you that, most of our grants that we write or trial proposals that we write about osteosarcoma start with, we've made no progress in 40 years. But I'm going to try to convince you that we've learned some things. So this is, again, using our population database in the United States. And basically what is being shown here is overall survival and over time and in different eras. So going from the 1970s to the most recent era of 2010 to 2016 in patients in the US, and it's broken up by age. So on the left side, I'm showing you that in the very young patients and the older patients, we actually have continuously over the decades improved outcome. I think this is most likely due to standardization of treatment and supportive care and things like quality of surgery and reconstruction, people learning how to sort of administer this therapy. So yes, we have improved, but in the ages of 10 to 59, which are the patients that we mostly see, these are the more common patients for us to see, you can see that in the first 2 decades represented here, there was an improvement in outcome. But for the last 3 decades, there's really been no change. Those survival curves sort of stack right on top of each other. But have we learned some things? Maybe. So I'm going to talk about mefamurtide. So mefamurtide, I think most of you in Europe know because it is an approved therapy, a regulatory approved therapy, but not approved for administration in all countries. For osteosarcoma, this is a component of the BCG cell wall that's sort of manufactured and is a very rudimentary immunotherapy. The idea is to kind of activate the immune system sort of generally. The rationale for studying mefamurtide in osteosarcoma was a randomized blinded trial in 27 dogs. And I'm showing you the results here. This is metastasis-free interval, and this is overall survival. And you can see that the dogs who received mefamurtide, or MTP, had an improved outcome. On the next panel here are the event-free on the upper and the overall survival on the lower of the Children's Oncology Group clinical trial of mefamurtide. This clinical trial had a very unique design. It was a 2x2 factorial design. So basically there were two ways you could get mefamurtide, either with or without ifosfamide. So half the patients who got mefamurtide got it with ifosfamide and half of them got it without. And The initial publication of this trial said that there was an interaction between the two therapies, which is biologically feasible because ifosfamide is very much a lymphocyte depleting chemotherapy, and you need your lymphocytes for your immune response. So it's feasible that these two had an interaction. The second publication with longer follow-up is the one that you're looking at here. And basically what you see is an improvement in overall survival that's statistically significant, but small, and an improvement in event-free survival that's not statistically significant. So that's the other sort of funny thing about this clinical trial, because usually in sarcoma we think people die from relapse, but not everybody dies from relapse. So you should have a bigger difference in event-free survival than in overall survival, but that is not what we see here. As a result of the two publications and the timing at which the company went to file for regulatory approval, there is variable regulatory approval internationally. So it's not approved for administration in the United States, but is approved in Europe regulatory-wise, but not by your health authorities in every country. And I think the sort of party line from the sarcoma community, at least in the United States, is we would like to restudy this in a clean randomized trial. But so far that has not been feasible, mostly due to ability to obtain the product for a clinical trial. I was not involved in this trial, so you guys can complain all you would like to me. I will try to be rational in my response. Yes, please, go ahead. They got only mefamotide. So they had amputation and then mefamotide. 27 dogs, I put the number there for a reason. It's a small number of dogs. Dogs are not humans, right? I mean, the biology of the disease is probably quite similar, but their immune milieu is very different, right? Anyone here, my dog eats turkey poop. Anyone in this room eat turkey poop? I didn't think so. Okay. All right. No, I do not let my dog lick me after she eats turkey poop. It's disgusting. All right, let's talk about ifosfamide. So here's ifosfamide. We have studied ifosfamide twice in randomized trials in the United States. Well, actually, one's a US trial. The other was our Uramos international collaboration. These were based on phase 1-2 clinical trials in humans with relapsed osteosarcoma that showed response rates somewhere between 15 and 30%. And I'm showing you two of those trials here. People said, well, okay, we see a response in patients with relapse disease. The next step is to bring that into newly diagnosed upfront disease. So I'm showing you the schema of the two trials. The first one was that mefamotide trial I just told you about, where patients received either regimen A or regimen B. Regimen B was adding ifosfamide to chemotherapy, and I want to make an important point here. Those patients got ifosfamide during induction and during maintenance. Okay, so pre-op and post-op, so neoadjuvantly and adjuvantly. But they were divided into half of them getting it with mefamotide and half of them getting it without mefamotide because of this 2x2 factorial design. The results of that trial are shown on the upper right-hand side. So this is the chemotherapy regimen. You can see that the EFS curves, I'm not showing you the OS curve, the overall survival curve, but it's the same. They are completely on top of each other. This was a negative trial. Ifosfamide did not improve outcome, okay? However, we really liked ifosfamide, and there wasn't much else to study, and some of us had been giving it with etoposide. There wasn't a huge amount of data about how much the etoposide helps, but anyway, they said, well, how about we study it again? And this time we did it as part of the international Uramos. I'm sure there were other really good reasons, but I wasn't there for the conversation. So anyway, I can't tell you about those. But anyway, this was Uramos, which was the international trial that was conducted between the United States and a number of European centers. And basically here, it's slightly different. The first 10 weeks of chemotherapy are just MAP. There's surgery, resection. For the patients with poor necrosis, they were randomized to either receive MAP or MAP plus ifosfamide etoposide, and the ifosfamide etoposide here is given kind of alternating with the adriel-cisplatin cycles, okay? And here again, the event-free survival curves and the overall survival curves are completely overlapping. So what we learned about ifosfamide from these two trials is the way in which it was given here, the way in which it was studied. Ifosfamide added to MAP or kind of interdigitated with MAP does not improve overall or event-free survival. In the United States, we use MAP because of this trial. However, that's not the full story on ifosfamide, okay? So ifosfamide, those are not the only two clinical trials of kind of approaches to chemotherapy and surgery in osteosarcoma that have been conducted. There are a number of other very high quality clinical trials done by a number of different groups, and many of them use 4-drug regimens that incorporate ifosfamide. And they have mostly done that to minimize exposure to anthracycline chemotherapy, to decrease the cumulative dose of doxorubicin. In the US MAP protocol, we use 450 milligrams per meter squared of doxorubicin. And at the time, there was no dexrazoxane. So a lot of clinical trials groups incorporated ifosfamide. And this is... there are 2 papers like this. This is from a recent review. I'm sorry, I forgot to put the reference up here, but by my colleague, Dr. Gorlick. And basically what they're showing is event-free survival from all of these different clinical trials. And then in the bold lines, the bold green and blue are the 3 drug regimens, which are mostly MAP, although not entirely. Some of them have some ifosfamide in them. Or 4-drug regimens, which almost all of them include ifosfamide, except for the few old trials that have that BCD in them, which would basically be giving the cyclophosphamide, we think is the active part of that. And what you can basically see is that 3 and 4-drug regimens have the same outcome. So whereas the bottom line here is showing you the 2-drug regimens, which are mostly adriamycin and cisplatin. Now, this is a fraught exercise because we're comparing across trials. And the problem with that is the eligibility is not always the same, and the population might be slightly different. But I think since it's such a large number of trials, it's probably an accurate result that whether you give 3 drugs or 4 drugs, you probably have the same event-free and overall survival. And so in general, I think that regimens that use ifosfamide in place of some other chemotherapy to sort of decrease the cumulative dose are just as good as MAP. And if you're using MAP chemotherapy, if you develop intolerability to a certain drug, let's say you can no longer get doxorubicin because you have cardiac toxicity. In general, I think it's a good idea to maintain your length of treatment and not stop giving all of that. And so many of us have used ifosfamide in that scenario. Questions about this? So not wrong to use ifosfamide because of those trials. It's just that if you add it to an already existing 3-drug regimen that works, it doesn't help. Yes?
What would you do in patients who have intolerability?
With ifosfamide or with cisplatin? Yes. So for those patients, that's a great question. I mostly treat younger patients. I treat the typical osteosarcoma age range. And that is much more common in the older patients, the sort of older adults. In general, I haven't had that much trouble, but I think many of them can tolerate ifosfamide. So I would probably, if I couldn't give any more cisplatin to my patient, for example, they got like 1 cycle of cisplat, I would probably swap in ifosfamide because I feel 2-drug therapy is not enough. Does that make sense? I don't know if other colleagues, I mean, we have Dr. Gaspard here who's also an expert, but.
As you might know, in France, we are using completely different chemotherapy. Okay. Then in France, we are using a completely different chemotherapy. Then we are using the MAKE regimen, which is methotrexate, ifosfamide, and etoposide for patients below 25 years. And the medical oncologist doesn't want to use methotrexate, then we are using EPAE, adriamycin, platinum, and ifosfamide for patients that are adult patients above 18 years. Basically, these regimens are well tolerated, as much as MAP can be. Yep. Then there is no problem of toxicity across age, at least up to 40 for the patients that are having APA. After that, they are using regimens that are adapted to the age and the fitness of the person.
of the patient.
And I think you also recommended this in the European Standard Practice Guideline for patients with MTX toxicity, right?
Yeah, then
So, yeah.
exactly. Then
Yeah.
when for the pediatric population, when we cannot do methotrexate, then we use API to
Yep.
stick to something that is known
Known
well
regimen.
standardized.
That's right.
To not use any regimen
Yep.
or any custom things.
So this is just incredibly important because if you're using a certain regimen and you run into toxicity with the agent, rather than just removing it and giving 2-drug therapy, you should look for another regimen that you can put that patient on that uses other therapy. This is such an important concept. So it's not that we've learned, it's not, oh, forget ifosfamide, it doesn't work. That's not correct. It's just you have to use 3 drugs and you should give duration of therapy that's, you know, an accepted regimen for treatment of osteosarcoma uses. Okay. And then we've learned about clinical risk factors. So this is from the Uremos trial. This is looking at the entire patient population with localized resectable disease who enrolled on the Uremos trial, 2,260 patients who received MAP chemotherapy. And the prognostic factors are tumor size greater than or equal to 1/3 of the bone. That's how they decided to do it in this trial, because if you're a smaller person, maybe you can have a smaller tumor. Being adolescent or adult, being male, having chondroblastic histology, having a proximal or axial tumor, or having poor necrosis, which again, they defined as less than or 90%, less than or, do it the other way around, more than 90% viable tumor after 10 weeks of MAP chemotherapy. And with that, the 5-year event-free survival is 60%, and the 5-year overall survival is 76%. The problem with the clinical prognostic factors, though, is they're mostly small. They have mostly small impact on outcome other than the necrosis. So like the hazard ratio will be, for male, is something like 1.3. It's a very small impact. So you can't really use them to identify kind of a high-risk patient group. For patients with metastatic resectable disease enrolled on the Uremos protocol, also receiving MAP chemotherapy, greater than 1 lung node. This is not from the Uremos trial. This is from the other reference that I'm showing you here. Having greater than 1 lung nodule or being unable to resect are the poor prognostic factors. The 5-year event-free survival is 28%, and the 5-year overall survival is 45%. So quite poor, and a lot of work to do there. So I'm going to move on now to talk about clinical trials of new therapies and overcoming barriers in that space. So the first barrier that we face is sort of thinking about response in osteosarcoma. So osteosarcoma has a calcified stroma. And this is another key take-home message that you have to be sure to learn so you can take care of these patients. So I'm showing you radiographs from 2 of my patients, pre and post chemotherapy. This patient is probably the best one to make the point in. So this patient's x-ray, if depending on who the radiologist was, may have read this as a larger tumor. And the larger tumor is just because you can actually see the tumor better, because with the 10 weeks of chemotherapy, the patient's tumor calcified. It developed a more calcified stroma. But in fact, if you look at this initial x-ray, you can see this sort of soft tissue swelling, which you don't really see in the follow-up radiograph. This radiograph's a little more subtle, but you can see there's a lot more lytic area in this radiograph, and there's much less lytic area here. In both cases, the tumor necrosis was greater than 90%, and the MRI did not have a RECIST response. So RECIST, is this kind of response, internationally adopted response criteria that has to do with tumor shrinkage. So you need to have tumor shrink, significant proportion smaller tumor to be called a RECIST response. And in osteosarcoma, we thought, well, we should actually, people always said, we're worried we don't see RECIST responses, not so much because of the inactivity of the therapies that we're using, but because of the calcified stroma. So we actually wanted some data about that. So we looked at our own institutional patients treated between 1986 and 2011 with osteosarcoma who had paired imaging before and after neoadjuvant chemotherapy, that MAP chemotherapy that has been shown in a randomized trial to improve overall survival. So if RECIST is a good way tumor shrinkage by RECIST is a good way to predict how well that treatment will work. You should have RECIST tumor shrinkage with MAP, right? Because it's been proven to improve overall survival. So we looked at this patient population, and there were 0 patients with RECIST response, okay? Tumors, osteosarcoma tumors, the primaries, now there's a caveat to this, the primary tumor does not shrink in general. You may see decreased swelling, you might see decreased edema in the bone, you may see changes in the enhancement pattern, but in general, they do not generally get smaller. Now, there's a caveat to this, which is that most of our trials in relapse are done with patients with lung nodules. Some of the patients will have sort of local or regional recurrence. We didn't have enough lung nodules here to tell you whether this result holds up for lung nodules. It sort of, I think, depends a little bit on how calcified they are. Okay, so instead, in the Children's Oncology group, we decided to generate some data that would give us an event-free survival benchmark. So we used previously conducted clinical trials in osteosarcoma in 2 patient populations that we encounter in the clinic at relapse. One of those is patients who have unresectable disease or measurable disease when they enter a trial, and the other are those patients who have lung-only relapse and have resection of those lung nodules. And we had enough patients, about 50 in the lower group and about 100 in the upper group, to develop an EFS benchmark that's very robust. So for patients with measurable disease, 12% of patients, only 12% remain progression-free at 4 months, and the confidence interval around that result is very clean. For patients with lung-only resectable disease, 20% remain event-free at 12 months. The confidence interval around that is a little bit wider, and that patient population is a little bit more variable. So this second benchmark is a little bit harder to use. With that, it really facilitated us being able to do clinical trials and understand clinical trial results in the Children's Oncology group and in other places as well, because we could do single-arm trials, and those trials could be done quite quickly with small groups of patients. So I'm just showing you some of the results from some of the Children's Oncology group trials, and I'm going to start with the clearly negative trials. So we studied eribulin, which is a tubulin inhibitor, and had some in vivo data showing activity in osteosarcoma, and denosumab, which is a rank ligand antibody, and there was some data in a genetically engineered mouse model to suggest that that might be active. But in fact, the 12-month progression-free rate, the 4-month progression-free rate was at close to that 12%. And then for the denosumab, we studied it in fully resected patients, and in fact, the 12-month progression-free rate was around that 20%. So those are definitely negative trials. So good, we got some things off the list to study, but not good for the patients because they didn't work. Some other negative trials is in HER2, which is a HER2 antibody-drug conjugate, and something called saracatinib, which is a Src kinase inhibitor. Some other things we learned from that, HER2 expression is complicated in osteosarcoma, probably not a great surface marker, actually, in spite of all this sort of early literature. And saracatinib was a randomized trial, and it was either in patients who have fully resected lung disease, and it was to either saracatinib or no therapy. And it turns out that trying to enroll a trial like that is actually quite difficult, because although the doctors and the patient both know that we don't know, like once you've resected that disease, whether you need additional therapy, many of the patients have decided what they want for their lifestyle and their preferences. So many, even though they know we don't know the answer, some of them will say, I only want surgery because I want to go back to college. And some of them will say, I want to live, you got to give me something to increase my chances of living. And even though we tell them we don't know what to give them to do that, they have strong ideas about it. Okay. Next are the things that have been studied that may have a hint of activity. So I'm showing you a phase 1 trial of this antibody-drug conjugate, which is to LRCC15 and has MMAE as the payload, which is a tubulin inhibitor, so probably not the ideal payload. And there were 10 osteosarcoma patients on this study, and there were 2 objective responses, and you can see the spider plot down there. So that's kind of borderline. This is Natalie's study, ifosfamide plus lenvatinib. And this was a randomized trial, which was great, of ifosfamide plus lenvatinib versus ifosfamide etoposide plus lenvatinib versus IE alone. And the pink line is the IE alone, and the IE plus lenvatinib is the blue line. There were a couple of things that so 20% of these patients who enrolled had resectable disease, and some of them had surgery, and that makes some of the final analysis of the results of this trial a little bit complicated, which is why it's on the possible activity slide. And then a couple of other things. There's an antibody-drug conjugate called glematumumab that had 3 of 19 patients progression-free at 4 months, which didn't hit our bar of being significantly over the benchmark, but it's better than the benchmark. And then this bottom trial was just presented at ASCO, azenosertib, which is a WEE1 inhibitor plus gemcitabine. And here, 38% of patients were event-free at 4.5 months. So you might say, oh, well, that's got to be a winner, right? It's like 2-3 times your benchmark. However, that idea of the benchmark is really, it only works for either novel combinations or monotherapy targeted therapy, because if you start to add in chemotherapies that might be effective, we don't really understand the benchmark for those therapies. Does that make sense? And so gemcitabine is actually used in relapsed osteosarcoma, and we don't have a great benchmark for gemcitabine monotherapy. And then here are some clinical trials done in recurrent and refractory osteosarcoma that showed activity. On the left are just 2 of the clinical trials of multi-targeted kinase inhibitors in osteosarcoma. The top one is a randomized trial looking at regorafenib versus placebo. And you can see that the placebo curve looks just like that benchmark event-free survival I showed you, so a nice validation of that. And then the regorafenib EFS curve is much improved compared to that. And then this is cabozantinib, which of all the MTKIs probably has the highest response rate. This is a waterfall plot of about 20%, and the 4-month progression-free rate is around 60%. All the other multi-targeted kinase inhibitors that have been studied in osteosarcoma also have activity. So as a drug class, this group is effective. However, in the relapsed and refractory setting with measurable disease, basically what you see is about 60% of patients have some activity. That activity is most often stable disease, and the duration of effect is somewhere between 4 and 6 months for those patients in whom it works. So it's not ideal. And then I'm just showing you this trial of gemcitabine plus sirolimus that was a single-arm trial performed by the Spanish sarcoma group. I don't think they reported the 4-month progression-free rate, but it's somewhere around here, which again is above that benchmark. But again, here it may just be that that's what gemcitabine monotherapy benchmarks looks like. We just don't know. There are a number of ongoing clinical trials. This is a selected list from the US with a US heavy perspective, and that's great. But this activity is relatively, let's say, uncoordinated. So even in the United States, we have a clinical trials group, the Children's Oncology group, but we also have people who are develop their own clinical trials. So in fact, I am the investigator for the olaparib ceralasertib trial, and it's not a Children's Oncology group trial, and I'm doing it kind of on my own. And then I'm just going to tell you about the newly diagnosed MAP plus MTKI cabozantinib trial, because that's sort of picking up on the relapsed refractory active trials. So this is our currently open Children's Oncology Group clinical trial for patients with newly diagnosed osteosarcoma. It's called AOST 2032. It's a feasibility and randomized phase 2-3 trial of cabozantinib in combination with cytotoxic MAP chemotherapy for newly diagnosed osteosarcoma. So patients enter the study, and they're divided into either being standard risk or high risk. The standard risk patients have localized resectable non-pelvic osteosarcoma, and the high risk patients have metastatic unresectable pelvic or pelvic tumors. In both cases, they're randomized to either arm A or arm B. Arm A is MAP alone, and arm B is MAP plus cabozantinib. In the high-risk patients who have metastatic disease, there's a slight difference to the schedule because cabozantinib needs to be held for 3 weeks before surgery, and then again for 4 weeks post-op, and confirmation of good healing, because it is a very strong anti-angiogenic and does interfere with healing. We have completed the feasibility phase and are modifying the protocol and taking it to all of our internal review boards to get approval to move to the efficacy phase. Okay, next topic, precision oncology for osteosarcoma. Any questions on the progress and the relapse trials? Any questions before I move on? Okay. Precision oncology for osteosarcoma. So my other hat that I wear, other than my osteosarcoma and sometimes Ewing sarcoma hat, is that I run a lot of our genomics programs at Dana-Farber and Boston Children's, and have been involved with some of our large precision oncology trials, both at our own institution and nationally. And the two worlds don't really meet, but I'm going to talk to you about how I think they will meet in the future. Okay? So what I'm showing you here are two lists of diagnoses from two different precision oncology trials. The trial on the left, the GAIN ICAT2 study, is a multi-institution study that we ran out of the Dana-Farber, where we enrolled patients with high-risk solid tumors. So those were patients who either had metastatic disease at diagnosis, had high-risk neuroblastoma, or already had recurrence. And 20%, fully 20% of the patients who've enrolled in this trial have osteosarcoma. So when I saw that, I thought, well, I'm just an osteosarcoma person, so that's why that happened. But this on the right is the pediatric match trial. That's sort of like our eSMART trial, and it's a basket trial that is enrolling patients with relapsed solid tumors across the entire country and for a sequencing protocol. And basically what you'll see is that 72% of the patients have non-CNS solid tumors, and that fully a quarter of those are osteosarcoma. So once again, osteosarcoma is the most common diagnosis on this study. I think that really just shows you the unmet medical need in relapsed osteosarcoma. We really don't have a lot of easily accessible trials for these patients, and there are a lot of them around, unfortunately. But in both of these cases, targeted therapy matches are rare, and when they do occur, they're generally supported by weak evidence because the common alterations are currently undruggable. So the most common things that we see in osteosarcoma are things like deletions in CDKN2A2B, P10, RB, TP53 is sort of universal and most often inactivated with somatic rearrangements. So none of those things have great drugs for them yet. We see amplifications in sort of common cancer drivers like MYC, CDK4/6, IGF-1R, MDM2. And we see a very chaotic genome. So in the upper red box is a karyotype. You don't get to look at that very often nowadays. But basically, the DNA, it's like somebody took an egg beater to the DNA of the tumor. Okay, the technical term for that is chromothripsis or chromoplexy. Those are two different sort of genes shattering events that can happen in the cell, where sort of the genetic material falls apart and then gets stitched back together. The bottom this is the modern way of showing that. That's a circus plot. And basically all the lines in the middle of the circus plot are places where the genome is rearranged. And then the red and blue is the next ring, which shows that amplifications and deletions happen at those sites of rearrangements, as do the mutations. So the mutations in osteosarcoma are kind of bystander effects. They happen at those areas where the DNA gets stitched back together. But I would argue, that I'm showing you pictures of 4 of my patients who've had metastatic osteosarcoma. They all have vastly different outcomes. And I think the problem is that we've done the genomic characterization and kind of understanding the patients completely separately. And in order to really subclassify osteosarcoma based on genomics and other features, we need to bring these two worlds together. Okay. And we need biologic subtypes. So this is a study that we've done. So we have sequenced sort of all of our osteosarcoma patients at our own institution and at some other institutions through these 2 studies called Profile and GAIN, using targeted next-generation sequencing. So this is like 500 genes, 500 cancer genes. And then Memorial Sloan Kettering has done the same at their institution. And so we took all those patients and we started to look for candidate genomic alterations that might correlate with outcome. This is the demographics of the patient population. I think the important thing to point out is the primary analytic cohort included that GAIN study, which are they were selected for being high risk. So fully 2/3 of the patients in the primary analytic cohort were high risk. And the validation cohort, most of those patients had extremity tumor, and all of them were localized patients. And we looked at a couple of different gene alterations, but we focused on MYC amplification, which we found in 12% of the patients in the primary analytic, and about the same frequency in the validation cohort. And in this primary analytic cohort, even though they were mostly already selected for having poor outcome, MYC amplification, which is shown in the blue, was correlated with a worse overall survival. That result is statistically significant. The event-free survival is also, the curves separate, but is not statistically significant. Again, because these patients were selected for being high risk of an event or already having an event. And then this is the validation cohort, who were those localized extremity tumors. And you can see here an even greater separation between the MYC amplified and non-amplified patients. And there have been similar findings reported in other studies as well.
Just one question. These were the primary tumors you looked at?
That's correct. Okay, so in this study, no. Yes and no. It's a mixture. It's a mixture. It's a convenience sample of like the tumors that we had that we sequenced. So I think, for example, in the validation cohort, it may be on that first slide. It's not there, but it's not all the patients. It really should be the diagnostic tumor.
Because if you look into the pulmonary metastases, and when you said they might, chemo not responsive anymore, this might have changed.
We did have a subset of patients who had serial samples, and we looked at that, and actually there's no clear pattern. But in some cases, the more common thing that happened was that the MYC amplification was lost, actually, when we had those series of samples. But this definitely needs a ton more work. It needs to be validated. Yeah. Other questions? Okay. This is a particular patient who had very aggressive disease, had bone and lung metastatic disease, progressed on treatment, and died, unfortunately, 10 months later. And this patient had 80 copies of MYC, and there were actually 3 similar patients to this in our cohort who had the highest level of MYC amplification. And in fact, you could even see the MYC amplification in the circulating tumor DNA. So this is his blood, and we did low passage whole genome sequencing of the DNA, the circulating tumor DNA in his blood, and we're able to see that MYC amplification. So there are a lot of people working on these candidate molecular subtypes in osteosarcoma. And there are, the MYC one absolutely needs to be validated, so we're working on a validation study now, using only diagnostic tumors, using patients who were, hopefully, at least some of them enrolled in prospective trials, and making sure. The other thing is that the cutoff for the MYC amplification is not clear. So this is not really something that's ready for the clinic, but hopefully we will get there from efforts on both sides of the Atlantic. So there's some other candidate molecular subtypes on the upper right. I'm showing you an EFS curve from looking at the burden of loss of heterozygosity. There's data in dogs and humans. Dogs and humans, showing that the extent of immune infiltrate in the tumor, if you have high immune infiltrate, then you have a better outcome. There's starting to be some literature on like 2 different epigenomic subgroups, which probably reflects like the cell of origin. And then we're starting to sort out like certain events in the genome that are associated with age. I want to say something more about circulating tumor DNA. So presented at ASCO, this ASCO that we just came from, circulating tumor DNA at the time, the presence or absence of circulating tumor DNA at the time of diagnosis Patients with localized disease is associated with outcomes, so patients who have higher circulating tumor DNA versus patients who do not have it is associated with outcome, as is decline in circulating tumor DNA at a very early time point. Again, that result needs to be validated. It's a prognostic factor. It is different than these other things that I've been talking about. So MYC, immune infiltration, epigenomics, they tell you something about the biology of the tumor that you can then work on and build on to create therapies, whereas circulating tumor DNA is a little bit more like an observation of a clinical factor, like, oh, that's probably some version of a higher burden of disease that we're not able to detect through things like measuring the tumor size. Does that make sense? But also, in circulating tumor DNA, you might be able to find some of those biologic features that are associated with poor outcome, like MYC amplification. Does that make sense? Okay. Okay, I'm going to try to do this part really quickly. So I told you that like using single genes to identify targeted therapies to give patients doesn't work that well in osteosarcoma. We've been thinking about this a little bit differently. We've been thinking about like a pathway. So DNA damage, response, and repair is the pathway that I've been particularly interested in. So there's an enrichment of germline pathogenic or likely pathogenic variants in DNA damage response genes in osteosarcoma patients compared to controls. 30% of osteosarcomas have signature 3, which is this sort of signature scar on DNA that comes about as a result of defective DNA damage repair. The relationship between signature 3 and somatic and germline alterations in DNA damage repair genes is unclear. But we do know that DNA damage repair genes are altered in some osteosarcomas. So this is a oncoprint of whole genome sequencing cases, and 90% of these cases had a loss of function variant in BRCA1, BRCA2, or ATR. Okay, this is important because BRCA1, BRCA2, and ATR complete loss of function is associated with response in breast cancer. I'll go through this really quickly, to olaparib, which is a PARP inhibitor. And in addition, there's preclinical data for activity of an ATR inhibitor, which is in that same pathway called ceralasertib. And so we decided to do a phase 2 clinical trial of olaparib and ceralasertib in patients with recurrent osteosarcoma. This is an investigator-initiated trial enrolling at 4 sites. And we're enrolling both the patients with measurable disease who would just enter and get the drug, and patients with resectable lung-only disease for whom we're doing surgery on study after 8 weeks of olaparib ceralasertib, so we can look at the effect of the drug on the tumor after treatment. Sorry, I'm going through this so quickly, but I don't have time. We are currently 5 patients away from completing the enrollment for this study. We designed this as a 2-stage design so that we had a certain number. I think we enrolled 15 patients in stage 1, and if we had a sufficient number of patients who met that 4-month progression-free rate, we could move on to the second stage. We were able to move into the second stage, and we're collecting a lot of correlative biology studies. So we have serial circulating tumor DNA on all patients, and we have FFPE slides on all patients, including patients who have those sort of paired pre- and post-treatment. So that's one big thing that we're working on. Another thing we're working on is to build that database of genomic and clinical data together. We have 2 approaches so that we can identify those biologic subtypes. We have 2 approaches. One is this direct-to-patient project called Count Me In, where we're sort of allowing participants with osteosarcoma to enroll in a study where we're going to do a bunch of sequencing and collect their clinical data just through the computer at home. It's called the OS project. And we're doing tumor normal, whole genome, whole exome, RNA sequencing, circulating tumor DNA. We're getting their medical records. We're looking at treatment and outcome. We are doing some return of results of the whole exome sequencing. We're doing return of results of germline by allowing them to get tested with a clinical company. We're planning to sequence 250 patients. And right now we have 270 consented patients, 150 germline samples, and 67 tumor samples from 60 patients. And we're going to combine that with this thing called Project Every Child, which is our children's oncology group tumor bank, on which we have 1,000 patients with osteosarcoma already enrolled. Not all of them have banked samples. And we're in the process of sorting out which bank samples are actually useful and which are not. And I can talk more about that for people who are interested in osteosarcoma and want to do research. You should learn everything we already have found out in the last 10 years about how difficult it is to use the FFP samples for research. Okay, last minute. Katie's tips for taking care of patients. These are just like the most common questions that I get asked. Okay, patient has had a biopsy and the pathologist is telling me the grade is unclear, or I think it's osteosarcoma, but I'm not sure. So the classic one is like a 16-year-old with chondrosarcoma. Epidemiologically, that's very uncommon. And so in those scenarios, upfront resection is not wrong. Okay, that's what I usually recommend, do an upfront resection. It depends a little bit. If it's a pelvic tumor, that would be hard to do. But in general, you just need more tissue, and you should either do an open biopsy, but sometimes just an upfront resection is the right thing to do. Learn to admit what you don't know, which is a lot. So one of the secrets to being an osteosarcoma expert is to be comfortable saying we really just don't know the answer to that. Uremos results, meaning don't add ifosfamide and all of that, do not apply to patients with progression on MAP. So if patients were on MAP, or any of our clinical trial protocols, if they had progression, they come off the trial. And so if you think a patient is progressing on MAP or whatever treatment you initially gave, give different therapy. It's like Oncology 101. But sometimes people interpret the results of uremos, which is you have poor histologic necrosis, don't change the therapy, it doesn't impact outcome, to mean never change the therapy. But if you have a patient whose tumor is growing or they have persistent pain at 10 weeks of treatment, don't just keep giving the same chemotherapy. Doesn't fit our principles. Maintain treatment intensity. Sarcoma patients should not have hair. Okay, and it happens in osteosarcoma mostly around the time of surgery. You really need to work with your surgeons to say, like, I'm getting nervous. My patient is starting to grow hair. And for multiple targeted kinase inhibitors, start low and go slow. We use a ramp-up strategy. If you start MTKIs at full dose in a teenager, 80% of them will come back and say, I'm never taking that medicine again. Okay, that's it. That's what I wanted to tell you, and I have 1 minute left. Questions? Or did you ask them all along the way? Sure.
You said that you still use a MAP in the US.
Yes.
How did you justify to the parents that you have a patient who received MAP and the tumor was completely vital, and you then continued postoperatively as at the adjuvant chemotherapy with MAP? Right.
So I'll go back to my last slide. There we go. So the way I deal with that scenario, which is very poor necrosis, So if it's 50% necrosis, we just keep giving MAP. If it's something like 20, 30% necrosis, so very low percentage of necrosis, I tend to look at all the other factors. What did the preoperative radiology look like? Did the was there a decrease in edema? Was there a, change in the enhancement pattern? And then I see my patients a lot during, even if I'm seeing them with a nurse practitioner or sort of advanced practice provider, I see them a lot during the first 10 weeks of therapy because I really care what happens with their symptoms. Patients who are responding to treatment, pain goes away after 5 weeks. So if the pain hasn't gone away, if there's any sign that there's radiographic progression, I will change therapy. If it's just the necrosis value, I usually continue MAP. Does that make sense?